So I would like to welcome our clinical course steering committee leader, Dr. Cindy Carlson, who is also the leader of the clinical core at Wisconsin ADRC, to the stage to kick us off. Thanks.
Thank you, Hannah. Again, thank you everyone for being here today. We look forward to our clinical core session over the next hour and a half. I think we, as chair of the clinical core steering committee this year, we really, our team really sought out input from you all and what you wanted to hear about. So identifying the webinars to hear, but the number one choice of topics people wanted to hear about was disclosure services. And we'll hear more about whether we call them disclosure services or services that relay back research results. So that'll be the topic of our session for today. But I wanted to start the session just by thanking our clinical core steering committee members. So again, there's 5 of us: Liana Pastelova, myself, Greg Jika, and Kostas Laketsis, and also Amy Pierce, for all their work in contributing to the steering committee this year. And then we welcome Doug Galasco, he'll move on to the committee as I rotate off this year. So thank you all so much for your input. So we're going to start by welcoming Dr. Amy Pierce to the stage. And as we've heard about earlier this morning, we'll be talking about UDS4 resources in some sessions that are coming up. So hopefully this will be a refresher. But I'd like to welcome Dr. Pierce to the stage. Here she is. So again, Dr. Pierce, she's the leader of the clinical core at OHSU, so Oregon Health Services University at the ADRC, and as mentioned, a clinical core steering committee member. So welcome, Dr. Pierce.
Thank you, Cindy, and I will be brief because we have very exciting topics to get to. This one is exciting too. So I was asked to just remind us all of some of the upcoming UDS4 transition resources, and certainly the wonderful NAC session this morning got us all thinking about how to implement the transition. I will be brief, but just to remind you, we are right here at the point where we're looking towards doing pilots, and ultimately, of course, we'll be starting UDS4 data collection in September of 2024. So in terms of the clinical resources for clinical cores, in terms of implementing UDS4. I think it's important to just make sure that we're all aware of those resources and take advantage of them. So obviously right now we can be reviewing the UDS4 forms on the NAC website, starting center-based team discussions on form content and workflow, even begin working through case examples and consensus conference even before we start the pilot. It's really quite helpful to review prior NAC sessions as well as CTF and clinical core webinars. Pilots sign up is by Friday, and we'll start getting more information on them next week. And next week is also the UDS4 clinical training workshop on Tuesday. So it's good to sign up for that as soon as possible, and it will be recorded if those need to watch it afterwards. And then I'll also mention that we're planning to have some upcoming open hours that will be hosted by the CTF to answer questions and review case study examples, and perhaps even move towards some opportunities for interactive consensus conferencing across centers. So just to point out, from the NAC website, prior UDS4 webinars have been very helpful, including the session recording from the clinical task force from our fall meeting when there were presentations on MBI, subjective cognitive decline, and cognitively impaired versus impaired not MCI. So those were brief sessions at last fall's meeting, but we also have had some webinars in the spring. So neuropsychiatric symptoms, MBI, and more was presented by Dr. Laketsis, and that, of course, is recorded. That was a great session, as was operationalizing impaired not MCI, led by Dr. Jika, but wonderful guest speakers as well. So reviewing prior sessions is a great idea. Also, the pilot opportunity, again, please sign up by this Friday, May 10th. And everyone should have gotten this email. There are 2 pilots, the NAC ID as well as the UDS-4 pilot. The UDS-4 clinical training workshop is next Tuesday, a week from today. Registration is open, and we hope that the training workshop will be highly interactive, so it's wonderful to attend live, to have the forms printed out and review, ask questions. We'll go through the forms with a focus on the new forms. And that's about it. Thank you very much.
Thank you, Amy. All right, so we're going to go ahead and jump into our session on disclosure. And so we have a really great lineup of 3 speakers today, but also 3 participants who are going to be sharing their perspectives on receiving back research results and other things. We've invited them to tell us other things, anything they want to tell us as researchers in the field of Alzheimer's disease. So we're thrilled to welcome them, and I'll introduce them before they come up, but also to welcome our speakers today as we talk about disclosure. So our first session is going to be led by Dr. Annalise Rahman-Filipiak from the University of Michigan on what do we know so far, current disclosure best practices and outcomes. And Dr. Rahman-Filipiak is part of the clinical core and the OR cores, outreach, recruitment, engagement cores at University of Michigan, ADRC, and she began leading the OR core in July of 24. She's also co-leading the disclosure core for the Clarity study. So I think some of you heard her speak the other day. So welcome, Annalise.
Thanks so much. Very excited to be here. I'm going to stand a little to the left here so I can actually see the slides. Really happy to be here, both again as part of the Michigan ADRC, but also as part of the Clarity team. I co-lead the Clarity Disclosure Core along with Lindsay Clark and Nate Chin, both of whom you'll be hearing from today. So one of the first things that we did as part of the Disclosure Core, many of you who were in the Clarity breakout sessions yesterday heard about this, was a survey on current disclosure practices and needs across the ADRC network. This was a replication of some work done by Scott Roberts in 2019. I'm not going to go through this in detail, in part because you can all refer back on the Hublot platform to the recording from yesterday, but what you can see from this table is that there really has been a significant expansion in not only the type of information that we're sharing back with participants, but also the types of participants with whom we're communicating. So not only folks who are cognitively symptomatic, but also to individuals who are asymptomatic. I hope to start today by making a case for why returning individual research results is so important. In the past, we've been hesitant to do that for a variety of reasons, not least of which was concerns about unintended harms to our participants. So I want to start by talking about some of those psychological risks. We've now accrued significant data to show that, for the most part, there are very few major psychological changes following disclosure. So participants do experience some transient test-specific distress. They may feel some anxiety about receiving the specific result that tends to diminish over the course of days or weeks. However, we're not seeing new onset or exacerbated psychiatric illness, including things like anxiety or depression. We're also not seeing adverse events, including suicidality, which I think was a major concern for many of us. I will say there are some caveats to this information. We have to first consider the fact that many of the participants in prior biomarker disclosure studies were specifically selected to have stable mental health at baseline, or they were part of clinical trials in which individuals with severe mental illness or substance use disorder were excluded. When we're thinking about larger biomarker development, dissemination, implementation, not only across our ADRCs, but also into specialty care, primary care, even direct-to-consumer, we really have to better understand the impact on a much more psychiatrically heterogeneous sample. Additionally, we want to think about other psychosocial impacts. There are a lot of impacts of disclosure beyond just symptoms of anxiety or depression. Several teams are now looking at other experiences, including stigma, self-efficacy, future time perspective, and even things like stereotype threat. So does knowing that you have biomarker positivity somehow affect the way that you perform on cognitive testing because of expectation biases? And finally, we have to consider that biomarker disclosure has a ripple effect. We're not just talking to participants, but to their family members and their communities. And so we are beginning to find that care partners may experience some level of distress or increased stress following biomarker disclosure to their loved one. Another major concern for many of us as researchers as we were considering launching disclosure or return of individual results is the potential for that information to end up impacting the participant in unintended legal ways. What I mean by this is that unlike genetic information, which is protected by the Genetic Information Non-Discrimination Act, biomarker information can technically be used against the participant or the patient. For instance, if we tell an individual that they do have amyloid positivity and they choose to share that information with their loved ones or their community members, they could be treated differently or experience stigma. But additionally, if that information is shared in the medical record, whether that's through a medical provider or us directly, that means that that information could be reviewed by insurance companies. It could lead to medical legal discrimination, like being ineligible for long-term care or life insurance. Now, when we think about some of these negative impacts, distress, discrimination, stigma, these are experiences that are already disproportionately affecting underrepresented groups. And so while biomarker testing has this amazing opportunity to provide access to and early detection and intervention with a broad group of people, if we don't do it well and very carefully, we could also contribute to existing disparities. So I think it really makes sense for us to focus on very thoughtful data sharing practices, not only with participants and their loved ones or with their medical providers, but also with other research teams, with each other, with our ancillary studies. Additionally, we need careful thought about pre-disclosure education. As I'm going to talk about later, we found that participants coming into biomarker studies may overestimate the utility of the information and underestimate the risks. So it's important that we think carefully about how to help people make informed decisions about whether learning their results is right for them. So now that I've gone through the bad news, let's talk about why we think biomarker disclosure is so important. So first, as many of you told us on that survey, participants want their results. And in fact, sharing results can be an act of transparency and can increase personal benefit in research. Additionally, we know from the IDEAS studies and other studies that when medical providers have access to this information, it can increase their diagnostic confidence, personalized treatment planning, and access to clinical care and research opportunities. And finally, from studies like RevealScan, we know that regardless of the result received, returning an individual research result can motivate the participant to engage in positive health behaviors like adherence to diet or exercise. It can help them better prepare for the future, and it can help care partners potentially prepare for their roles. So now I'm going to shift gears a bit and talk a bit more about an actual framework. So one challenge about disclosure up until now has been that there were not really protocolized or centralized resources for disclosure. That thankfully has changed quite recently. So Josh Grill and others led a group last year that developed some best practice guidelines for the ADRC network. Similarly, Emily Largent published a really nice paper, a kind of 5-step framework for disclosure. So I'm going to lay out some of those steps in a bit more detail. So in addition to interpreting and labeling the data, it's important that we determine the appropriateness of disclosure for each participant or study. We also want to engage in that pre-disclosure education, consent the participants, ensuring that they have decisional capacity to make that specific decision. We want to communicate both the result and the limitations of that result, conduct some level of comprehension check and assess psychological reactions, and finally engage in some kind of post-disclosure counseling. Now this may look different across different sites, but I'm going to go into detail a bit more on what this could look like. So first, in terms of mental health screening, one of the things that we care about a lot when we're determining appropriateness of disclosure is whether or not returning an individual result might increase risk for some of these negative psychological outcomes. Participants considering disclosure should have stable and positive mental health. But what this means is that it doesn't necessarily contraindicate disclosure for individuals with some level of anxiety or depression, but rather that individual has to have sufficient coping resources and stability in order to be able to cope with whatever possible outcome. How we determine if a person has stable mental health really differs based on the individual in front of us. So selecting your pre-disclosure screening measures kind of depends on the sample you're looking at. So for instance, if we're in a clinical trial setting in which we know individuals are highly screened already and do not have significant mental health history, you may use a short screen. However, if we're looking at community populations or just individuals with where we know little about their mental health history, we may use a more comprehensive screen. Certainly, if there's evidence of prior mental health conditions, it's important to complete a more thorough interview. You may integrate other measures like the Columbia Suicide Severity Rating Scale, but you want to integrate not only information about current symptoms and acute stressors, but also things like their past and current mental health treatment, things like their social support and coping resources. I finally want to mention that both before and after biomarker testing and returning the results, we want to make sure that there are pathways for our participants to receive mental health support if needed. We're not trying to toe the line of being a clinical service, but it is important that participants have access to those services outside of our study. So for instance, at Michigan, we have a lot of participants who come to us through the Michigan medicine system, but we also recruit heavily in areas like Detroit and Flint, where mental health resources are not as easy to access. So our team has done a lot of work to identify community-based sliding scale fee mental health services that even participants who are uninsured or underinsured could access. To shift gears and talk a bit about education, again, at Michigan we found in doing qualitative interviews with participants considering biomarker disclosure that they often overestimated the type of information they would receive from a biomarker test and underestimated the risks. That really pointed us to the need for pre-disclosure education that reviews not only the procedures involved and what's involved or what possible alternatives exist, but what a test will and will not tell the participant. Many participants believe, for instance, that a biomarker test will tell them how many good years they have left, if they should stop driving, what kinds of cognitive difficulties they may develop. We also want to talk about the risks and benefits of learning results for that individual participant and encourage them to talk to others in their lives, not only their clinical providers, but other decision supporters in their lives. The modality of education really differs based on the study format and the resources available to you. We have done one-on-one pre-disclosure education sessions, but that's likely not a scalable model. So there are various resources that are already available through things like the ADRC website. So what you see on the screen is a decision aid for individuals with mild cognitive impairment who are considering amyloid imaging. This was developed through the AGREED group, which is the Advisory Group on Risk Evidence Education in Dementia, freely available. In terms of communicating results, we take a 4-step approach. It's very important that you ground the result in a headline. So the amyloid test was elevated. An elevated amyloid result means there's a significant amount of abnormal amyloid in your brain. You want to describe it in terms of the etiology. So this result means that there are Alzheimer's disease brain changes already occurring. If the person's cognitively impaired, you want to talk about the relationship of those cognitive impairments to what we're seeing on the biomarker testing. So this result means that your cognitive difficulties are, at least in part, likely due to Alzheimer's disease. And finally, you want to talk about risk. So while it does not guarantee that you'll develop dementia, this result means that you are at increased risk in the future. One of the things that we are less comfortable with is talking about our limitations or uncertainty. It's not something as scientists that we love, but it's important that as part of our disclosure, we do talk about why we can't release certain information. So we can't give specific numbers or a specific risk estimate. In the case of a negative result or a non-elevated biomarker result, we can't guarantee that the individual will remain that way in the future. Importantly, we want to emphasize that we cannot rule in or out other neurodegenerative conditions or medical conditions. We know participants can sometimes feel like Alzheimer's is the only thing that they can focus on, and instead there are often multiple pathologies and sometimes multiple medical comorbidities that are much more treatable. We can't predict if, how, and when decline will occur. Accurately combining risk factors is very complicated. And an important point that I think we've been talking about across this session and yesterday in the sessions is that we have limited representation of underrepresented groups in biomarker development research and even in biomarker disclosure research. I don't think that means that we should not disclose to diverse individuals. I think it means that we have to be comfortable saying, these are the best data we have at this time. We think that these biomarkers perform potentially the same, but the reality is that we need to do a better job of recruiting in order to better understand risk relationships. Another important piece of biomarker disclosure is assessing comprehension of and reaction to results. You can do this in a range of ways. There is a formal comprehension test that you could give, but you can even use teach-back methods, which many of us employ in our clinical settings as well. Additionally, the extent and timing of your psychological assessments after disclosure really depends on the population. However, we have found that reactions to biomarker results can change over time as participants process their results, talk with their doctors, identify pathways forward, and share them with their loved ones. So we do recommend having some kind of safety check that occurs maybe 1 week post-disclosure. In terms of future directions, I'm not going to talk too much, in part because Lindsay's going to come up and talk about what's happening next in the disclosure space. But we're very excited as the Disclosure Core for Clarity to produce this disclosure toolkit. Again, want to emphasize that we are not trying to be prescriptive. There are many of you out there who already have very well-developed return of results protocols. We want to learn from you and collate this information so that we can really leverage the strength of the ADRCs. But the outcome that we're really hoping for is that we can test disclosure in a much broader population, a much more diverse population, so that what we're doing is culturally and community informed. I'm going to stop there and just quickly acknowledge a few folks. In addition to the Clarity team, I want to particularly thank the participants at the Michigan ADRC who really trust me and my team with a very vulnerable time in their lives, and also all of the wonderful colleagues and mentors that I have at Michigan and beyond. Thanks.
Thank you, Annalise. Our next speaker is Dr. Lindsay Clark. Dr. Clark is a clinical neuropsychologist, and she is a clinical core co-leader at the Wisconsin Alzheimer's Disease Research Center and leads the disclosure service and the neuropsychology service within our clinical core. And she'll be speaking on future directions in disclosure practices. Welcome, Lindsay.
Hi, everyone. Thanks for being here today, and thanks to the organizers for inviting me to speak with you. Also slide a little to the side here. And thanks to everyone online for listening as well. So Annalise mentioned the survey that you all were so kind to fill out about what you're already doing at your sites. And so what we know right now is that about half of the ADRC network are returning amyloid PET results to their research participants. 11 are doing so routinely, and 8 sometimes. And fewer sites, not surprisingly, are disclosing tau PET results with participants, but none routinely, 4 sometimes and 2 rarely. Reasons that sites do not return results are common reasons are that it wasn't part of the original study design. Concerns about those potential harms of the information to participants. Practical barriers like not having time or staff available to conduct these visits, and concerns that results aren't clinically actionable or they're collected in a way that doesn't meet clinical regulations. And then related specifically to tau PET, more concerns about the validity of the cutoffs used or the meaning of the results, which makes sense because visual read procedures are still being developed and validated for tau PET scans. One of the reasons that, or before I move to this, but all of the sites or the majority of the sites indicated that they would like or are interested in sharing back biomarker results with participants in the future, and that they would benefit from having some resources to do so. So today I'm going to talk a little bit about ongoing developments and just remaining needs to facilitate this process. One of the barriers or reasons that results aren't returned is that it's not part of the original study design. And so I'll just briefly talk about a protocol that we developed in Wisconsin based on what had already been done in the field through the A4 study and other clinical trials. We amended our protocol to add this process for returning results to participants, and I'll walk through each of these steps briefly today. So first, we added an informed consent addendum to provide an opportunity to discuss the process for having an option to learn results if participants are interested. We talked through them about the risks and benefits for learning results, the process by which we could do that, and really asked them if they were interested. So that starts with the informed consent. We also have some educational materials like a brochure that we use to help participants kind of think about this decision and whether this is something they're interested in. As Annalise mentioned, there's a lot of work still needed in this area of how do we provide best, brief but effective education about biomarker testing, about the interpretation of results, and help participants or patients make a decision about whether they want to learn their results. And so there's a lot of development in the field about kind of using some interactive tools and things that are being developed to do this better. But that's one remaining need. Currently, we share back the results through a verbal and a written report. So that's, as Annalise mentioned, helpful for participants to have that in multiple formats and be able to take the result home with them. Our study clinicians contextualize the result within their clinical stage or any known risk factors. Some sites share back a visual image of the scan so that participants can kind of see what it looks like. We ensure people understand the result by asking them to tell us back what they heard and clarifying anything as needed. And then we provide space for participants to be able to ask questions, whatever, individually is important to them, so that we feel like they leave with the information that they need. Still a lot of questions around how much post-disclosure or post-communication of results support and resources are needed or expected, and who benefits most from these resources or who needs these the most. And how can we as ADRCs in our communities better create pathways and resources for our participants to be able to take next steps if that is what they want to do. This might be related to clinical follow-up, so providing information about clinics that are available if that's something that they're interested in, or providing other resources about planning, support, education, etc. Oops, wrong button. When we first started sharing back our biomarker results, specifically our amyloid PET results with participants, one bottleneck that we ran into, not surprisingly, was lack of clinician time. And so we quickly realized we needed to train additional clinical staff to be part of our disclosure service. So we brought on a couple of nurse practitioners on our team, a social worker, we already had a geriatrician, we have a psychologist now, so now there's 5 of us and hopefully continuing to grow. We asked our clinicians what helped them as they were, kind of getting involved in this practice, and they found that the training on Alzheimer's disease, biomarker testing, and interpretation was helpful, having the hands-on learning and collaboration with our team, and also having patient-facing materials and some checklists to help facilitate the communication of the results was really helpful. We also found that we needed to invest in coordinator training and effort, so continuing to, remaining needs are how do we have the resources on our coordinator team to be able to help with things like pre-disclosure consent and education, scheduling of these visits, and post-disclosure support. I forgot to mention earlier that in addition to providing resources, we also offer optional post-disclosure visits. And so we have a social worker who can meet with participants and talk with them about community supports and resources. We also have another member of our staff who can meet with participants to go over some individual dementia risk reduction strategies. So, kind of building up resources like that within our team as we're able to do so can be really helpful. Thinking more broadly outside of the ADRCs too, one of the barriers to dementia diagnosis has been lack of clinician training, or clinicians not really feeling confident in being able to evaluate or diagnose cognitive impairment. So I think as a field, the more that we can develop some resources and develop educational materials and trainings for clinicians to be able to disseminate into the communities in the future, that will really help as biomarkers become more widespread in clinical practice. Currently, we share back a binary amyloid elevated or not elevated PET result based on a visual read. But there's interest from our participants in learning more detailed quantitative information. So we've talked as a team about, could we provide something like a centiloid value, or more of a high, intermediate, or low range, or our site also has investigators working on measuring how long a person has had amyloid plaques in their brain. Would this information be useful for people? And so what we really need, or what would be helpful, is to know how exactly these values translate to more specific information about risk estimates, prognosis, or specific treatment recommendations above and beyond that kind of binary elevated or not elevated result. So that's research that we're kind of continuing to work on. As we all know, there's more biomarkers coming out, and so continuing to validate clinically meaningful cutoffs for tau tracers as well as blood-based biomarker tests are needed so that we can accurately communicate those results to participants and patients. Communication of multiple biomarkers, how do we provide a lot of information about different processes happening in the brain in a clear and concise way that still makes sense to people. We, of course, lack biomarker tests for non-AD diseases, and we heard yesterday about exciting developments in that area, so that will continue to be needed. And we also need more specific risk estimates that take into account multiple biomarker tests as well as other factors about individuals that can impact their individualized risk trajectory. We talked a lot about this yesterday, I think, in the biomarker core and the imaging core session, that a majority of the information that we know about biomarker interpretation and communication of biomarker results is from a majority of highly educated and white adults. And so, this lack of inclusion limits our ability to interpret biomarker tests and communicate biomarker tests with people of color. And also, this can have a negative impact on our science when we have this kind of lack of representation in biomarker validation studies. It can lead to disproportionate screening out of non-white people into clinical trials, which can potentially make our treatments less generalizable. So we all know this is a big theme of this meeting, is really improving the inclusion of our biomarker validation studies. And also, we want to think about cultural factors related to how results are communicated and what recommendations are provided. So it can be helpful to have a protocol, but there's really a need for site-specific cultural adaptation of the information we provide. And so we need to be soliciting feedback from our community partners, from participants, from caregivers, others involved, so that we really can adapt this information so that it's culturally relevant. Additionally, this was already discussed earlier, so I won't go into it in a whole lot of detail, but a lot of the information that we know about psychological reactions to learning results is from participants who are enrolling clinical trials or in observational cohorts. And so it'd be really great if we could gather more data on how people react to learning biomarker results across the clinical spectrum, from those who are cognitively unimpaired at risk through those living with dementia and their family members. It'd be helpful to know more about populations more similar to who we see in the clinic or the general population, so that we can better understand potential reactions to learning results. And I know today we're talking about biomarker results, but I think this is also important when we just think about diagnoses in general. So giving someone a diagnosis of mild cognitive impairment or dementia, and really that being more informed by the biomarker test that may say they have Alzheimer's disease. Additionally, lots of other outcomes that are interesting to learn about in terms of how people may react to learning a diagnosis or learning a biomarker test result that still need to be studied. And particularly looking at what people do with this information. Does it motivate them to seek further evaluation or treatment? Do they engage in health behavior changes to reduce modifiable risk factors? Do they change plans for the future, and if so, how? And so all of that would be really helpful for us to better kind of quantify the benefits to learning early diagnosis or biomarker test results. Annalise mentioned these as well, so there are available resources for those who want to learn more about returning biomarker results to research participants. I believe all of these were mentioned earlier, except for the Pittsburgh ADRC has a toolkit of materials they use that they share online, and so those are also available. As part of the Clarity study, we'll be developing some additional materials and rolling those out through the network so that there will also be those available for the Clarity participants or other participants. And these will also include some training resources. So a training manual, kind of more specific details about how do we actually do this, how do we communicate this kind of uncertainty, and hopefully having some interactive training sessions or webinars as well. As far as the toolkit development process, we're planning on testing our initial toolkit with some pilot sites across the ADRC. So thanks to those of you who in the survey indicated you might be interested in being a pilot site, we'll be in touch. We'll also be getting some participant input on how things look as far as the materials go or what adaptations need to be made, and then we'll finalize and disseminate that toolkit and continue to update it as we move forward. So adding Tau PET disclosure materials once we feel like those are ready. So I want to just take a moment to thank the disclosure service team at Wisconsin, who are a really great group of people wanting to help share results back with our participants. I want to thank my site leaders for being really supportive as we developed this process. And I want to really thank our participants who are the reason that we do this and who we continue to learn so much from every day. I'm more than happy to answer questions later, or feel free to contact me over email if you're online. Thank you so much.
Thank you, Dr. Clark. And our final speaker is Dr. Nate Chin. Nate is the Clinical Core co-leader at Wisconsin ADRC and medical director of our Clinical Core. He's also the host of the podcast Dementia Matters, which many of you may have listened to. He may have interviewed a lot of you in the room, too. So Dr. Chin's going to be speaking to us in disclosure case discussions, so trying to put this into more of a practical context. So welcome.
Thank you, Cindy. I wanted to start right away in the stage because I know my timer just started, so thank you. And I'm here to present two cases from the Wisconsin ADRC, just as a way to show you a potential process in sharing amyloid PET results back to a research participant and some considerations for that conversation. A fair amount of time goes into preparing for the visit with the research participant and their study partner. And you can see here in this slide the steps that we take as clinicians at the Wisconsin ADRC. So in addition to looking at the actual result, we also review what we call a note to file document. This is a safe, protected space for our research coordinators to share important background or contextual information that the clinician might find helpful in preparing for the conversation. Two examples would be a research participant who has a sibling who is also in the study who has learned their amyloid result and whether or not that would be relevant for our conversation. And for me, if I've seen them in the memory clinic and now they're here in the research setting. We also will review the ADRC research summary, which is a combination of research information as well as clinical information. You can see the things that we look at here, but this also includes the cognitive testing summary, as well as any comments that were made during the consensus conference. We will review the psychological questionnaires that both Annalise and Lindsay spoke to, making sure there were not elevated responses when it comes to anxiety, depression, or any comments about suicidality. We'll lastly talk with our research coordinator about anything that came up the day of the visit and any particular questions that the study partner or or the research participant bring up, particularly if they're clinically relevant. So for my first case, this is a cognitively impaired individual with elevated amyloid. So he is a 79-year-old man with a bachelor's degree, worked in management. He has a father who had Alzheimer's disease, a mother with Lewy body disease. He did have a clinical evaluation in our memory clinic and was diagnosed with dementia, thought to be due to vascular disease and possible Alzheimer's. His symptoms started 5 years prior, but they've gradually worsened over time. In the upper right hand, you can see some of the medical history, which includes some vascular conditions as well as depression and anxiety. And he's on medications, appropriate medications for these, as well as an assortment of supplements. He's been with our program for quite a long time, 2 decades. And in the first decade, he was cognitively unimpaired and doing well and stable. He then gradually progressed to mild cognitive impairment and then most recently dementia. His exam was notable for mild increase in tone in his upper extremities, as well as a mild left hand intention tremor and a stiff appearing gait. His research information you can see at the bottom of the slide. We see the remote infarct from the past, as well as moderately advanced chronic small vessel disease, which we look for, but his research labs are relatively unremarkable. Now, this is a screenshot of one of the many forms we use in our disclosure visit or returning results visit. And you can see from the title that we do utilize a semi-structured interview approach or format. So we have 4 or 5 standard questions that our clinicians will ask the participant. And this is a way for us to assess if the participant is truly ready to hear this information. If we feel it is safe to share this information at the time, we can always delay it to a later visit if needed. And so we're asking, what is your experience with Alzheimer's? Will that experience impact how you hear this information today? What are you going to do with this information? And then we will ask a research question about their willingness to enroll in a clinical trial, and then end with an opportunity for them to ask us any remaining questions before they hear this information. We have a suggested script for our clinicians, which really is meant to emphasize that we are using very specific intentional language, and so it might sound mechanical to them. But afterwards, when we answer their questions, it will feel more conversational, and we'll have plenty of time to talk to them. We have a step-by-step process, which you can see here, where we really do pause when they've heard everything. We want them to process. We don't want to rush them. And then when they're ready, they let us know when it's okay for us to start asking questions. We are observing for any sort of behavioral response, emotional response during that time. Now, this is a screenshot of one of our forms. This is for a person living with dementia. And as you can see, it shows the participant name, the date that they had the PET scan, but then very clearly your amyloid result is. It's either elevated or non-elevated. And after that is going to be the explanation, what this means to them in their clinical context. And on page 2 then is a glossary of their term, of all the terms that we use. And I will say that the participant and the study partner each get their own sheet. They can take this home with them. They can do what they want with this information. But they are looking at it as we are reading it to them verbatim. So they are hearing it and seeing it at the same time. Now, our post-disclosure process really starts with the teach-back method. What did you hear? What is your amyloid result? And then what does that mean to you? Is this what you expected? What questions do you have? Do you have questions about your risk of having Alzheimer's disease or how this impacts your clinical or research diagnosis? We do have a separate section that if they bring up questions or concerns about safety, about privacy, about how they share this with their family or preventative measures, we will record that as well. So some key points that I made to this particular participant are listed here on this slide. It starts with this information does not change your clinical diagnosis or your research diagnosis of dementia. It does increase the likelihood that Alzheimer's disease is contributing to your dementia, but I always clarify the definition of Alzheimer's disease is the presence of both amyloid and tau, and I don't know their tau result at this time. I speak to co-pathology. This is one test looking at one particular disease. I cannot speak to TDP-43, alpha-synuclein, Lewy bodies, or vascular disease. Now, in this particular case, we had information clinically relevant, so we did speak to vascular as a likely contributing factor. But there are other modifiable risk factors, other health factors that we will speak to. Oftentimes that will come down to sleep, medications, and mood. But ultimately the conversation will come to the next steps and care options. And so in this particular case, we brought up talking to the primary care provider, having a referral to the memory clinic, talking to the county agency or your area agency on aging. Now, anytime we talk about clinical care, we do explain the implications of sharing this information. If a healthcare provider enters this into the medical record, that is a medical legal document, and therefore they should be aware of what could happen with that information, as Annalise has mentioned earlier. We will talk about medications. Oftentimes people ask about supplements, and then more recently we have been talking about lecanemab. Now, if this participant had had MCI instead of dementia, the conversation usually feels different, and it does progress in a different way. And that's because how people interpret this is going to be individual, but we do see differences when it comes to a cognitive cohort. So in Wisconsin, we tend to notice our participants with MCI are more eager to learn this information. They are also more anxious. They want to know, well, how high is an elevated result? What is my number? Tell me about that tau PET scan. What is my risk of progressing? And so they're very focused on understanding the future, understanding risk, and then certainly other causes that might be contributing to their symptoms, and then interventions to help them. On the right of this slide, you see our explanation for individuals living with MCI. So you see that it's longer. There's more information that we tend to share for our individuals living with MCI. Now, many of our participants who are impaired will ask the question, well, what do I do now? And we will try to answer that to the best of our ability during the actual disclosure visit, but we often want people to have more opportunities or more time to ask those questions and learn information. And as Lindsay said, we do have a team member, a social worker, who will meet some point later to go over education, to talk about advanced care planning, and mostly to go over local resources that might be relevant to them as a research participant or to the study partner who might be their care partner. Now for case number 2, this is a cognitively unimpaired individual with elevated amyloid. She's a 64-year-old African-American woman with a master's degree working in business. She is hoping to retire in the near future. She has no family history of dementia, no prior clinical evaluation, but she has had symptoms for the past 2 years and feels like they're gradually worsening. So you see in the upper right hand her medical history, which includes some vascular conditions as well as insomnia, chronic pain, and depression and anxiety. She's on appropriate medications for these, although I do highlight that she was taking Tylenol PM for her pain and insomnia, as well as regular use of tramadol. Now, she's been with our program for 6 years, and so she's had 3 research visits, all with normal cognitive testing. But despite that normal testing, she continues to report changes in attention, short-term memory, word finding, multitasking. There's no functional impairment, but she feels like she's less efficient. Now, her study partner denies any particular concern, though is more worried about the stress she's under at work. So you can see some of the research data that we have on her. Her MRI scan was overall unremarkable, and there were mild abnormalities in the research labs that we got. Now, we do have a different summary document for our cognitively unimpaired individuals. So it's the same top, it's the same participant name, date, and results, but how we explain the meaning of this to someone who is technically cognitively healthy is slightly different. It is more similar to the MCI document, but each varies to some degree. When we think about key points that we explain to our cognitively unimpaired individuals, we break it into 2 groups, the things we know and the things we don't know. And so as you can see on this slide, I said that elevated amyloid is not a clinical diagnosis, that she does not have Alzheimer's disease because she doesn't have amyloid and tau, but she does have an increased risk for Alzheimer's and progression to Alzheimer's dementia. Now, I spend more time talking about what we don't know, because ultimately she wants to know her own individual risk, and I can't provide that information to her. I don't know if she'll progress to having tau, if she'll have symptoms. And I will often refer to the Nunn study and this idea of resilience, this importance of some level of uncertainty. I'll speak to copathology as I did in the other case, but then I'll also focus a lot on modifiable risk factors, lifestyle factors, and for her, talking to her about obstructive sleep apnea, mood, medications, and chronic pain. Now, we will talk about stigma to each of our individuals, no matter what cohort they're in, but in particular for the cognitively unimpaired, it's really important for us to bring this up so that they're aware of societal stigma as well as self-stigma. And I have seen many patients or many participants start to attribute all of their mental changes, all of those moments where they walk into a room and don't know why, to their amyloid. And I will bring that case up to explain to them, please don't do that and think about the other factors that might be affecting your health. For this particular participant, I also talked about the limitation in our interpretation and meaning of biomarkers in people of color. And we know why that is. The majority of these studies are done in white participants. So this is probably more relevant if her result had been not elevated. But it also allows for me to thank her for her participation, for giving to our study and helping improve the representation of our research. Ultimately, people want to know about next steps, including the unimpaired, and so I'll still talk about clinical options, but I spend a lot of time talking about risk reduction counseling, as well as how to approach sharing this information with their family and friends if they choose to do that. And then lastly, of course, the idea of clinical trials and enrolling in those. Thank you.
Thank you, Dr. Chin. I'm going to pause now and welcome to the stage. We have 3 guests here today, so I'd like to have them go ahead and make their way toward the stage. And again, I know we're all multitasking, we're all here, but I'd like everyone to close your laptop and welcome our guests to the stage today. Great. We are so honored today to have these 3 participants joining us today. So on my far right, on your left, we have Ms. Carol Turner. So she has flown in from Virginia to be a part of this panel today. So we're really grateful for her being here. Ms. Turner is a participant in the AHEAD study, which is one of the largest Alzheimer's prevention studies that is ongoing currently and has been a part of the ACTC, or Alzheimer's Clinical Trials Consortium, and has done some speaking for them, trying to increase awareness. So I'd like to thank, I think you referred to her as your agent, Sarah Walter from ACTC, for putting us in touch with Ms. Turner. Ms. Turner is a wife, a mother of 3 daughters. We compared notes on kids, and she's a grandmother of 3 awesome grandchildren, it said. So she's a resident of Portsmouth, Virginia, and a caregiver for her mother and aunt. And we'll hear a little bit about your story as you speak today. In 2021, Carol became a research participant for the East Virginia Medical School AHEAD study, and she's on the Clinical Trials Consortium and does advising for the Clinical Trials Consortium, which focuses, again, what we're trying to do is to improve our understanding of how can we better serve research participants and learn from them. And she's in the advisory board, and she has some unique experiences going out to communities, speaking to churches, and trying to increase awareness in African American communities about engagement in Alzheimer's research. So again, we really appreciate your being here, Ms. Turner. In our next 2 participants, so in the red sweater here, we have 2 colonels up on our stage. So we have Colonel Joellen DeBerg and her husband, Colonel Oak DeBerg, as well. Colonel DeBerg is, and they've been a couple for 62 years, so congratulations on that. So they've both been a part of the U.S. Air Force for over 30 years. Joellen, I guess they're both colonels, so Joellen DeBerg, she's been an ICU nurse and has worked as a flight nurse. She was the first military nurse to serve as a congressional fellow, and she has numerous degrees, and also now, adding to her accomplishments, is a spokesperson for persons living with cognitive changes and speaking in front of a group like this today, right? So. And then Dr. DeBerg, too, again, is her, as I mentioned, her lifelong partner and has been also served in the military for over 30 years. I think you said between the two of you, it's been 45 years, right? And I understand you've had a couple of careers. So again, in addition to working in the Air Force in engineering, he also, after his first retirement, he also has a doctorate in philosophy and is, I think you're trying to retire again from University of Texas, San Antonio, teaching philosophy there. So, and I want to thank both of them for being a part of here, and to thank Dr. Seshadri for helping. She's their agent to help us to have them join us today. So again, welcome to the stage as well. And so for both Colonel DeBerg and Ms. Turner have had amyloid scans, and so we asked them, and I'll kind of guide them through some discussion about what it means for them to get their amyloid results, and also I've invited them to share anything they want to tell us researchers. So again, we do appreciate that, and I know we've talked about this before, that each person's perspective is one person's perspective. So we understand that we don't expect that you're speaking for anyone more than yourselves, but again, I think the more perspectives we as researchers hear about, talking with our own participants, our patients, and then hearing from guests such as our guest today is really important as we think about things like working with veterans, working with African American communities too, and getting more and more of those perspectives. So we will welcome those perspectives as well. So I'm going to come sit here next to And Ms. Turner, I know you've had some comments you wanted to share, so if you want to go ahead, and we've asked them to kind of prepare some remarks, and then we'll have time for questions from the audience as well.
Yes, I did. Thank you. Thank you so much, Cindy, Sarah, who's always sending me an email. I gave somebody your information, and I thought you might want to talk to them, or they want to talk to you. So I'm just glad to be a part of this forum, really. Of researchers. And my journey kind of starts with my dad, who was 93. As a matter of fact, he was a month from his 94th birthday when he passed with Alzheimer's, and he had battled that for quite a number of years. And because of that, my mother, who was his caregiver, started showing those signs. But the thing about it is, my mom didn't have that on her side of the family. Her side of the family was more with the heart issues. And I guess because she did caregive for a while, a lot of times that's why it's so important for caregivers to take care of themselves, because they tend to get sometimes the worst end of the deal after the fact. And that's kind of what we're dealing with now. During the time that we actually talked about my mom, we had her we took her to a primary care physician, and he referred her to her heart doctor, who in turn got us in touch with Dr. Quabi and the EVMS team over in Norfolk, Virginia. We were in a session wherein we're getting results for my mom and noticing that, first of all, she is past the point of even being able to be in the study. She's like 86 then. But he showed us a picture of her plaque, which is the first time we'd ever been introduced to anything like that. So to be introduced to that and Dr. Quabi has a way of telling you things that don't seem like they're bad. I mean, we see it, but it's helpful. It's helpful because if you're first time being introduced to that, it's something that you really need to understand, and you really need to get a grasp of it, simply because my dad's side of the family, he had already had 3 other siblings who passed from it. He's got 2 sisters now who have dementia. Okay, so it's running rampant on this side of the family. As we are talking, he talks about the HEAD study getting ready to launch. And he asked my brother and I, we have a study coming up, and it's for the ages of 55 to 80. Would you like to be a part of it? And we Sure, yeah. I mean, it's like we didn't feel as if we had a choice in this thing, because if we don't do something, we're going down the same road. So it was blessed that we had the opportunity to even be there to know that. We wouldn't know that. And that's another thing about in the African American community, a lot of us are not in the presence of things like that. A lot of us will not go and seek it out. That's why you have to take it to them, because they don't understand it. Being researchers, I know you guys are like deep, okay? And a lot of times, a lot of the language that's used or a lot of the materials that are printed may be like above someone's head. So it's a lot of times that African Americans may not understand things, and because we don't understand it, we don't want to bother with it. Sometimes for fear that it might be something that we don't want to hear. But it's nothing wrong with making it available and making yourselves available for that. And that's simply what we do with Purple Sundays. Now, mind you, I wrote all this stuff. I'm not reading any of it, but I mean, this is so near and dear to me simply because of the history, of my family history. And I have friends. I have other friends who have family members that are affected by this. But when you come to actually really sitting down with our Purple Sundays, as a matter of fact, we had one this past Sunday, we seek out contact people in the African American churches, and we have them advertise the Alzheimer's presentation and the Ahead Study presentation. And they register individuals for that presentation. We go to the churches, it's 5 of us, Dr. Kwabi, Dr. Nick Najad, who's his assistant, Dr. Andrews, who is a pharmacist at the Hampton University, in Hampton University, and Dr. Gibson, who's an RN at ODU, but she teaches nursing at Norfolk State University. Now, mind you, Dr. Andrews has a mom right now who is in hospice from Alzheimer's. So she's caregiving for her mom. What she's done is a part of our presentation is a video of her mom's progress so that the individuals that we're actually presenting to can see this thing firsthand if they've not personally experienced it. And plus, she also speaks on it as well, which is very helpful. And everyone is available for questions and answers. Just to look at the faces on the or the people that are participating in these church events that we're having, I mean, it's mind-blowing because they really hunger for the information. What better way to give it to them than to go and give it to them if they don't come to you, which a lot of them will not? Then it'll be too late for them to get help for their disease once they find out, especially for the study, because there is an age limit for it. It's so rejuvenating, I think, to even be able to be a part of something like that. I would never in a million years think that I would be placed in a position that I'm in. This is just a new season in my life. And I'm loving what I do with it because I'm a helper. I mean, I like to help people, and a lot of times put myself in the background. I know the plaque in my brain. I'm one of the high level plaquers, basically. But I'm hoping after my 4 years, I'm in the study for 4 years, I'm in it now 2.5. So I'm 2.5 years into the HEAD study. Getting my MRIs regularly, doing my memory tests. Some of those tests now, I don't know who came up with them. But when they come to, yes, probably I would like to talk with them personally. Because when it comes down to that grocery list, I bomb every time. The grocery list, everything else, writing, everything else, I'm cool. Grocery list, I make my own grocery list and carry it with me to the store. So that's kind of what I'm talking about. So things like that, you kind of got to look at it at a point of view wherein a lot of people are not even really going to understand what they're about to embark upon. So it has to be clear. It has to be a partnership. It has to be, you have to come out of your box and come into an area that you may not be, because your researchers are like behind the scenes, so to speak, so not in the forefront. Some of them, if some of you are, just charge it to my head, not my heart, because I don't know every individual person, but I do know that it really is important that you think about different levels of thinking where this disease is concerned, because it's scary. I mean, and it's sad. And no one wants to go down that path, but if you have the information up front that you need in order to understand. I know when I had to go in the office for my process, starting my process, I was given paperwork that I had to read, but they allowed me time to do that, of course. And it was probably like 7 or 8 pages, front and back. So that alone is kind of scary. So you got to start Googling stuff, and Google is my friend. Google is my friend. And it helps. But the thing about it is, if the documentation is lay person ready, it makes the world of a difference. And also, if it's provided, if the provider is giving it to you in a way that you understand it, and that if there are any kind of confusion about it, because we African Americans a lot of us are afraid of researchers. Now, even when we go to our Sunday sessions, we talk about Tuskegee, because that's a myth. I mean, well, it wasn't a myth really, but it actually happened, but that's not what's happening now. So to get them to understand that this is a different day and time, a head study, I sat back and watched the stop gates, watched the security measures, it's so detailed. Everything is so timed. I have to take my blood pressure only in my right arm, things like that. And I talk about that just to let them know that these people are really concerned about your health and your well-being. And there's no reason to be afraid, because if you need to know something, and if you want to back out, you can back out. That's the freedom of it. You don't have to stay in it. But we want you to. And this is how you can understand exactly what's going on. Ask what you need to ask. Make sure that, I'm going to have to go back to my notes for this right here, because I did write some good stuff down right here. But look. We went to a brainstorming session in San Diego. Not San Diego. Yeah, it was San Diego. And some of the brainstorming, I'm on the advisory board, and Cindy mentioned that. And we had a brainstorming session that we wanted to provide researchers with information. Some of the suggestions were to reach out to the primary care providers, to build trust and a rapport with your participants, being culturally sensitive, forming partnerships with communities and clinicians, partner with communities to ensure relevance, encourage innovative approaches, consider barriers that may exclude a participant from being involved, ensure materials are not too scientific. Now, I have written down here, you guys are deep. Y'all are real deep, and I appreciate it. Sometimes I just don't understand it. Another important thing, the process that it takes to sign up and get to where you need to get with the infusion, it's long. If there is any way that could be streamlined, because you could lose a lot, and probably are, I just don't know. We could lose a lot of people in the process because, first of all, you're wondering, were we forgotten? Or, why is it taking so long? I was the first African American to participate in the AHEAD study in the nation. That's crazy. Thank you. EVMS was not the first site. Why am I the first participant? Because the word is not getting out like it should. That's why. Everyone are not privy, like I was privy to, have that presented to me. So a lot of that needs to be taken care of. Participants are a fundamental and indispensable part of research, offering firsthand experiences that pave the way for others. Without their involvement, there is no data. Without data, there is no cures. Without cures, the quality of life is compromised. Data from the African American community is vital. We don't have it. We don't have enough of it to show if it works for us. I'm fine. It works for me. I still have 2 legs, 2 arms. I know my name. I'm fortunate. But a lot of people do not understand what I understand. Researchers, I have something nice for you. I deeply appreciate each of you representing your diverse roles for your dedication to advancing Alzheimer's research. As I think about my children, grandchildren, future generations, I hope and pray that this disease doesn't afflict them. Your timeless efforts in battling this challenging condition gives me hope. Collaborating and partnering with us participants can only add to the progress that you've already made. Thank you so much.
Thank you so much, Ms. Turner. Now, Colonel DeBerg, I'd like to hear from you and your husband. I know, Colonel, I'm going to call you Doctor and you Colonel, just to keep things straight. So, I understand, so you have had some family history of Alzheimer's in your family as well. Do you want to talk a little bit about that? Do you have there you go, you got the microphone. Do you want to just share a little bit about your family history of dementia?
Well, don't know really where to start here, I guess. My mother had Alzheimer's disease, but the interesting part of it was, I'm the oldest of 4, by the way, and was kind of the one who took over when there wasn't anybody else to take over. That's what you get for being the oldest, if you will, and that's okay. But even as a teenager, I watched my mother deteriorate a little bit, actually a lot. But as the daughter, you don't think in terms of a little bit or a lot. So the only reason I bring it up is because I know that that's there, and the minute that, or I felt like, all of a sudden, I was changing. I served on active duty for over 30 years, and I had done okay in the military, made ranks all right, and all of a sudden, I didn't quite have everything on my fingertips that I needed to have. And the reason that was important to me is not just personally, but I'm responsible for entire squadrons and later on the entire hospital. So I guess the only part that I want to bring forward is that I knew when things started to deteriorate, shall we say, and it was continues to be frightening because of what I had to do with, or because of my mother, is the bottom line. As the oldest of the others of my siblings, as she deteriorated, then obviously I pick up more and more responsibilities until I was pretty much running things pretty good, and I thought I was pretty hot stuff. Mm-hmm. And then I met this guy over here, and we got married, and my world changed for the better, But the only reason I bring it up is that I felt like I had a lot of responsibility at home. I got married, ended up in the Air Force, had lots of responsibility there for over 30 years. And I only bring those into view because throughout all of that, I recognized that I was a little rough around a lot of edges. And you don't want anybody else to know that. especially if you're in the Air Force, because that would show a weakness, if you will. You don't do that in the Air Force, probably the Army or the Navy or the Marine Corps either. But I bring it up because I acknowledged changes were happening. And you don't like to, one, acknowledge it, but mostly you don't like it to happen. So I think all I can really say is that I feel like I'm working hard to combat it, to pretend like I'm normal, like most other people are. And I recognize there's a lot of weaknesses there. What? Oh, well, I have a sister that I've lost. I have one that's still going strong, by the way, but the one that I lost, it was very traumatic. And she was a very strong personality lady, and she was in charge. She was the one who knew everything and let you know she knew everything, which was fun. But she went downhill very, very quickly. And as my husband brings to my attention, I found that probably more difficult to deal with than losing my mom. But she's gone, and now we're just driving forward and keeping on trucking. And I guess that's really all I have to say. I think I'm hanging in there, but I acknowledge that there's a lot of gaps and weaknesses, and there's areas that I can certainly improve upon, but I just work on those a little bit every day. So that's all I have.
Thank you. Thank you. And we talked a little bit at lunch too, because you had one of those amyloid scans with Dr. Seshadri too, to see if your memory changes that you had noted were really from Alzheimer's disease. And we talked a little bit about, but if you want to maybe both kind of share, was that helpful to get those results to kind of clarify what it was, or how did you respond to getting those results?
Well, before I answer your question, I'd like to thank Dr. Seshadri, Sudha Seshadri. She changed our life, really. And kind of taking up what was just said earlier, you know, we're not in any kind of unprivileged community. We live in a very privileged community, and it was still hard for us to find out how to get appropriate treatment. Our primary care physician told Joellen several years ago that she should see a neurologist. We picked one out of the phone book. Believe it or not, there were phone books. And went to see him, and he gave the standard questions, and he said, "Oh, you're fine. You don't have anything to worry about," and that was it. And we knew there was something wrong there, but so we didn't do anything until we were quite fortunate to just attend saw in a newsletter for our community that Dr. Seshadri was going to come and give a little talk on Alzheimer's. And I talked to her afterwards, and she took us under her wing and is doing, from a family perspective, a wonderful job for us. So thank her when it's all over. But yeah, so Joelle and I, if you can figure by our age and how long we've been married, we got married right out of high school, and it was evident even then that Joellen's mother had some issues with memory. My mother, who was a nurse, met right before our wedding, actually met Joellen's mom, and she said to me, "There's something wrong with that lady." And back then, Alzheimer's, I don't even know it was a term because I'd never heard it. This was in 1960. And she said, "But there's something wrong with that lady's memory." And so the rest is history. Joellen talked about her mom, who died at the age of 70 from Alzheimer's. Her sister died at the age of 69 of Alzheimer's. And so that's kind of the family history. And our daughter, who's also a retired Air Force officer, is now getting into the program with Dr. Seshadri, because she has three children, three grandchildren, and she's worried about what might be their future. And so this is an ongoing saga, and if we're around in several years, we might be back to tell you how it's going. Yeah, so to get to your question, in terms of getting information, obviously we'd like all the information that you all have at your fingertips, and we understood everything you understand, and we're both relatively decently educated and can understand questions. If you hand Joellen a piece of paper, she'll read every word and keep calling back Dr. Shashadri's people, say, what does this mean, what does that mean? So the 7 or 8 pages might take forever. But I believe I can speak for both of us, we welcome all the information we can get. Now the problem is, since listening just to what happened earlier, you don't all know everything it means. And so when you talk to us, this number doesn't equate with some objective statement you can make. And so we're here saying, well, what does it mean? And all we can get is your best judgment. And we welcome that. And we understand that you can't tell us, well, this means X, Y, or Z, and this is what you should do to plan for the future. And Dr. Shashadri has shown us Joellen's scans and has told us qualitatively what it might portend and what it means and what we're going to look at. Joellen's in, I'm going to say this wrong, Dr. Shashadri, but the Lequimbi study. And so her first scan in that study will happen next week. And so we'll start seeing how that progresses. But, and I understand what you were saying about people's apprehension at getting results, because we have friends that, that I think probably wouldn't want not to know, because if things appear negative, even if that's not what you're actually trying to say, they become worried. I've got relatives like that about any disease. They get something that looks a little negative and they think they're going to be dead in the morning.
They're all Italian.
Yeah. That's true. For those, that's not an ethnic joke. My mother's maiden name's Sinatra. So there's a long history there between the two nurses. Yeah. So, actually listening to the previous discussion with the slides and so on, I'd be interested in reading some of the literature myself so I can more understand what you are all saying and know what your issues are with talking to patients and how you do it. But for what it's worth, I teach philosophy and critical thinking, and one thing I can tell you, facts do not change people's minds. People think emotionally.
Exactly.
And that I can guarantee you, because I teach logic, and that won't do it. And one aside, and then I'll hand the mic to the other folks who can probably say more important things. I, as the potential caregiver, am very interested in finding out whatever I can about Joellen's progress, conditions, and so on, because there are factors, social factors, and family factors that feed in from my perspective, like, what do I do? Do I have to find a support group? What do I do for estate planning? Joellen, we believe in autonomy and being our own decision makers. So Joellen can make her own decisions, but what happens at some point when she can't? What do? I know what I think she wants, but not always. Yeah. Take it. So this is a multifaceted problem, and I wish I had hours to speak to you individually, because it's fascinating, but I won't hog the mic, so all yours.
Thank you very much for sharing that perspective again. It's definitely a family condition, and that we're not living in a silo, that we live around each other, and these conditions affect others. Now, one thing we talked about over lunch too, Ms. Turner, if you don't mind speaking, so we talked about how learning what amyloid scans showed, like what the cause of your cognitive changes were, and then for you being part of the AHEAD study, so you knew that if you had an amyloid that was elevated in your brain, you could be a part of the study. We talked a little bit, like what if there wasn't an AHEAD study and you didn't have symptoms, Could you tell us the group a little bit about kind of some of your thoughts on what would you do if you were, you don't have symptoms, but if there wasn't a study to be a part of, what kinds of things you'd want to know from research teams to be able to take kind of action on that information?
Well, a couple of things really, because I would want to know, where do I go from here? What's available for me? What can I do for myself if I can't find, or if there's not a study that's coming pretty soon? What can I personally do for myself? I know it takes a whole lifestyle change. I'm in a preventative study. I have I'm just putting it in the atmosphere that a lot of that's gone because I am in a blind study. So I would want to make sure that I am well equipped for really the unknown. Do I take meds? Can you refer me to, the doctor needs to tell me what to do basically. I'm not gonna know what to do. Because first of all, for some people, they're gonna be in shock to even be able to see an image and see that your plaque is like all over the place. So I'm gonna need you to tell me what I need to do. Tell me, I know personally what I need to do. I need to eat right, I need to exercise, I need to be active, I need to do, keep my mind busy. Other than that, medically, what can you offer me? What do I need to do? You from a physician perspective, because I don't know.
Thank you. If there are other questions from the audience, we have a few more minutes left in the session. We decided that we would take most of the discussion to be able to talk with our participants, because we know that you know how to reach Annalise and Nate and Lindsay. And so, and we will have a half hour after this to touch base with people, to touch base with them, but also our participants. But if there are questions that others want to ask our participants, if you want to come up to the microphone and share those thoughts, and we'll keep talking in the meantime. But if there are a few questions before we finish our session. But while we're waiting to see if others have questions, are there other things, again, as this research program across the country gets started in how to share back these research results, things like these brain scans, the amyloid scans, and then now tau scans, which shows other proteins. And as we learn more about the disease, what kinds of things would you find helpful to know ahead of time as you're coming into these meetings that would help our teams make sure they have good information prepared to share with people? You have thoughts on that?
I really, one of the problems is staying abreast of what is coming on down the line, if you will. So it would be nice to know what questions to ask when we meet. Because when we met with Dr. Sheshadri, she will tell us something that is not secret, is that we should be aware of, but unless we spend our time becoming WebMD researchers, and even that might not work. But we wouldn't know what to ask. And as a matter of fact, when the last time we saw Dr. Sheshadri, she mentioned something after Lequimbi that was coming down the pike, and we talked a little bit about it, and we looked at each other. Neither one of us had heard of it, and so maybe that's our failure, not being sufficiently engaged. But we just thought, well, that's interesting. It's not going anywhere with us, but it would be nice to know about. So if there is a way to keep people, it's kind of the opposite of your problem of getting people to get any information or want to get the information. What is out there? What should we be thinking about? And does it fit in the regimen of care somehow, or will it? At least we could ask the questions, because if Dr. Sheshadri hadn't mentioned it in passing, we probably still wouldn't know about it. And it's not that we're going anywhere with it. It's just how do you stay abreast of it all? I mean, everybody has either patients or doing research in their own little areas. How do you share what's going on all around with us commoners, if you will? Other than that, I can't think of much. I wrote down on my question pad there, a lot of the literature you just threw up there as pictures that all of you know about. I didn't know about half of that, so I'm going to go find it. But just to read it, just so you stay informed. Because without information, you can act without information, but you probably act foolishly. So information is what I would suggest. I don't know. You have anything to say?
No, I think.
And I was kind of thinking about maybe a forum wherein you have participants and you have researchers there, and have the participants ask questions in reference to meds, in reference to the steps that you're taking to help combat this disease. How do you go about knowing what to do for what patient as far as level of amyloid plaque that you have in the brain? You have somewhat low and somewhat high. What is an amyloid? I mean, have them, or a researcher could actually break it down to participants and help them to understand their journey, because that's basically what it is. So I just think the more you have a relationship with participants and collaborate, I mean, we have things that you may need, you have things definitely that we need, so the two can be together. So I think if you have that sort of thing, I think that'll help a lot.
Thank you. Do we have a question being put here? Yes, Sumi.
First, I want to thank you all. It's just so marvelous to have you here. It means so much to us, and you're, of course, extremely lucky to have one of the best docs in the world, so congratulations. So I just had sort of a casual question. I mean, it sounds like the three of you have had thoughtful conversations with your docs and getting results, and I'm wondering, have you heard of other folks that have had a similar situation where they've walked away with questions, or do you have any other perspectives that you've heard from people that have gone through the same process as you and have insights about how we could make it better?
I guess the thing that, the answer to your question for me is that my sister died recently, not too long ago, and she's 8 years younger than I am. And so her deterioration came, in my mind, very quickly, that less than 3 years. And so having gone through that, I guess I'm pretty afraid, a little frightened every time I can't remember something. All through high school, then after that, private organizations, I joined community theaters and played roles and had a grand time up there on stage. And then all of a sudden you wake up one morning and you think, darn, I can't remember the lines. And that's kind of, to be perfectly honest, frightening. So you say, okay, this is the last play I'm going to be in. I'll be happy to introduce everybody else, but no more plays. And I guess the bottom line that, rather than take so long to talk, is that the hardest part for me is having to acknowledge that I don't remember everything I'm supposed to remember. And why is that? Did I turn dumb overnight? I don't think so. It's been a gradual process. But I guess I found a plateau that I can accept and just keep on trying and working at it. And thank goodness I've got this guy next to me that kind of keeps me on track.
If I understand your question correctly, do we see anybody else going through it? Is that what your question was?
Any lessons you think you'd want us to learn?
Yeah, I don't know anybody in particular other than her sister. Personally, we've met a couple of people that find it hard to get into any kind of system or don't realize that they're having a problem. But other than that, none specifically. Yeah, her sister, by the way, and her husband lived in Bahrain, and her husband was noticing some minor issues there, and they lived in Houston. They would come back to Houston, and they weren't to see neurologists, and it wasn't going very well. They went back to Bahrain, and the Bahraini doctors instantly said, "You need to get back and get some help because she's probably got Alzheimer's," and did all that. So it was a back and forth, and so the issues with them getting care, I don't know if that answers your question, but it was not a smooth transition from, hey, we see something's wrong, let's go get help, and it all worked out. So it's probably not a good answer, but that's about the only thing I can think of. Yeah.
Thank you. Do you have anything to add?
Yeah, I think that I personally do not know of anybody, because it's almost another thing. It's almost like you don't. When we're in the infusion center, that's when I might overhear another participant that has joined the study. I may hear them talk, and then I just pull the curtain back, and then we start talking. Now that's a lot of times my brother might be there too, so I introduce him to whomever. So I've kind of met people in the infusion center, and if they and I have answered questions in reference to my experience about and that process thing was a biggie with a lot of people that I've talked to. So other than that, that's kind of how I've shared my experiences as opposed to maybe their experiences.
Thank you.
Thank you.
All right, this will be our last question. We'll wrap up. I apologize that we're a little bit over. Yes, please.
Actually, I don't have a question. I just wanted to personally thank you for being here today. I think this is very, very important. To the organizers, we need to have more of these types of panels. They're very important, and you really glean a lot of information. And lastly, to the colonels, thank you for your service.
Yes. Thank you. Thank you. I have your audience here. Yes, thank you. I do want to second that. So again, thank all of you so much for being here, to drive from San Antonio, to fly from Virginia, to be here to share this perspective. If you want to come up and talk, I'm going to offer your time afterwards. Come up and talk to them, welcome them during our break session. But again, thank you all for being here. And we'll keep learning from our participants. Thank you so much.